And I played basketball, as you can clearly see. And I played for a little college in North Carolina, Davidson, but always admired Villanova. Sorry about your early departure for men's basketball, but I'm thrilled about the University of Virginia. We had a great run this year. And just as a note, because that note is a note you hit when you walk into the door of this College of Nursing. And that is what Tony Bennett teaches as the heart of his basketball team. Anybody know what the word is? Servant. Compassionate basketball took him to the Sweet 16. He has what his father taught him as servant court, and it's to share the ball. To share the ball. And it really is a remarkable thing to watch. We're a rough group of kids who managed to go places without the talent, but because of compassion and service. And I say these things by way of introduction because we're about to talk about technology and how technology is going to influence all of your practice. Everyone in this room, and especially you guys who will leave here to perform important work in healthcare, telehealth and the tools of technology are going to be very much a part of what you do every single day. But we cannot forget in the midst of this that at the heart of all this is using technology as a disruptive, please check that, strike that on the recording. That would be disruptive force in terms of human relationships, how we translate this to something meaningful. And that's what I want to be able to talk about tonight. So we love to call this thinking inside the box, looking to see in what ways we can translate that image of ourselves to be a force for healthcare. That's a picture of myself to remember who that's me. And I clearly wear a lot of hats, and I appreciate what you had to say, because one of the most disruptive elements of telemedicine that is so extraordinary is that it requires interprofessional practice. You've got to engage with medicine. You've got to engage with engineering. You've got to engage with community organizers, with government, with broadband people, with telecom people. It involves many, many different disciplines in order to make this work, and that's what makes it exciting. What I wanted to be able to do this afternoon is just give some overall orientation to what telehealth is, in particular telenursing. And let me just put a shout out to that. Take hold of the title. Language matters, right? We don't want to let it become telemedicine because it's not just medicine. It's nursing, it's education, it's social work, it's mental health care. So our choice is to call this telehealth, find the right definitions, give an overview of this, and then look at some best practices, look at where this is going, and importantly, I want to talk about applications in rural communities and in global communities, and the opportunities that this can provide you. You will have a place in the workforce. If you know telehealth, and you know nursing, and you know global issues or cultural issues, you go out there, you're going to be in an incredible position to make a difference and have an extraordinary experience in your professional life. And so I want to be able to talk about that and the fundamental role of nursing in telehealth. I don't just say that about nursing because I'm married to a Villanova nurse, okay? I genuinely know and understand for all my years' experience in this that telehealth functions because it's been driven forward by nurses. a lot of creative physicians, a lot of creative engineers, a lot of creative and talented people, but nursing is at the heart of this, and I want to be able to talk about how we use it in Virginia. So there it is. There's the definitions. So can somebody tell me what they think, all those definitions aside, what telehealth is, what it means? So what is telehealth? Go look at definitions. What is it? Oh.
I think it's an opportunity to provide health care to a patient who might not be able to make it into the hospital or to come to your office.
Right, so it's a provider somewhere, right? Using broadband technology to reach someone somewhere else.
I usually think of like when you have medical problems or you need to ask questions, you use the phone to contact some kind of health provider.
Yeah, it's everything from plain old telephone services. We literally, in the business, we call it POTS, plain old telephone service. All the way from the tin can and the string up to FaceTime and Skype. How many of you Skype in here? How many of you have ever sent a picture over your smartphone to somebody? You know, this is part of our everyday life. It is not separate from it. And so it is a provider connecting to someone in need using every range of technology over broadband. And so it's not just medicine, it's not just the issue of medical diagnosis, it is that, it's treatment, it's follow-up. Other language things that I would like to point out that is very important. When we began this, we always said, oh yes, we're connecting to a remote site. You know, the person that's there is not in a remote site, they're at home or they're in their home community. And we need to be very conscious that they're not remote, we're not establishing outposts, that rather we're the place where the patient is, or the family, or whomever we're caring for, we call the originating site. Makes a lot of distance. And the place where the provider is, guess what? The provider site. Makes a lot more sense, doesn't it, by way of language. And so we're in this transformation now to move from telemedicine to telehealth, including telenursing. Now let me ask, is telenursing a formal part of the curriculum here? There's not a course, but maybe.
We include some aspect of it through the courses.
Right, so it's starting to, and I think that's important. Right, it's not, and I want to say something about this, it's really not to be thought of as something separate from what we already do, because you don't have a course here called the stethoscope, right? And so telehealth needs to be naturally incorporated into the curriculum as a whole. That's the way, exactly the way to think about it. But I want to say, for all of you in conversation here at this great College of Nursing, that now's the time. There's a real advantage to being a leader in this because it has not emerged. There are a few colleges of nursing, a few programs out there that have begun to be a leader, but it's not clearly established. And it's an opportunity where engineering and nursing and medicine and architecture, I mean, my role in architecture is to create the virtual healing environment. That's why I'm there. And so it is to put all those pieces together, and there's incredible opportunities. So I wanted to say something about the origins of telehealth. So the person who can answer this gets the prize tonight. what were Alexander Graham Bell's first words on the telephone? Hello? Can you hear me now? Watson, come here, I need you. So the first transmissions were of a copper line through acid in order to make it, and he knocked the acid over and he burned his leg. And so the very first phone call ever was a telehealth call. So, and I know, it's funny, but actually next year, and that call was, I think on March 13th, I think was the date of the 18, whatever it was. And so next year, we're going to have a World Telehealth Day on the first day of the first phone call. And I think that's right. That's what changed the world about how we communicate with each other. Now, something else was said that I think is important, and that was, this will never work. Well, the same things have been said about telehealth as well, that it'll never work, and it has taken off. That radio news that you see there, 1924, Hugo Gernsback, the radio doctor is in. That's picturing a child at home seeing a pediatrician over a device that didn't even exist at the time that that journal came out. There wasn't television, but there's always been the sense that we are moving in that direction, that reaching into the home, reaching to where people are, having healthcare be a part of everyday life is an important part of all of this. And it's been going there. Mass General, of course, they claimed the first telemedicine clinic. It's at Logan Airport. They set up a television studio because the doctors didn't want to drive to Logan Airport from Harvard. Nebraska did telemental health in the 60s. We in Virginia, we've been doing telehealth for some 20 years now. So it's broadly applied, and throughout it all, from the beginning, critical to the nature, the very first contract that we ever laid out to do telehealth, it required that there be a nurse there present at the originating site in order to ensure that telehealth worked. And so it's been really since the beginning, and the experiments that Harvard done, that's been part of that history. I don't know if you guys, any of you guys, are doing historical inquiry, or you know of graduate students who are interested in historical inquiry in nursing, but here is a heck of a subject to write about and research. It needs to be published. The story of the leadership role of nursing in creating the environment to have this revolution happen. So yeah, it's about the technology, but as I said earlier, it's all about the relationship, and that this technology is disruptive in the sense that the care provider on the one end, likely a physician, a specialist, requires that hands-on relationship with the nursing on the other end. It is a level of trust and commitment and communication back and forth that changes the very nature of that practice in ways that I think are very important. And it creates opportunities for the application of this practice that are important. It's not to have a course in stethoscope. It's to integrate the stethoscope into the mission of what we do. It's in order to find a way to bring these kind of capabilities that I'm going to talk about into our mission of what we do. I put this picture on the top because for a long time, for 40 years, telehealth has been very important in Alaska. And does anybody know what happens when a health clinic burns down in the middle of winter in Alaska? It burns down. You can't, you can't spray water on it. It's not going to do you anything. And one of the stories we like to tell about a remote Alaskan village was when their clinic caught on fire, the people in that village went in to rescue their telemedicine unit to get that out of there. It was so important to them as a community because it was their lifeblood of connection back from a remote, and that really is remote, place to be able to get care. And ever since, I mean, there are extraordinary tales that are told from around the world about how this technology transforms lives. There was a physician researcher in the South Pole who developed a very virulent form of breast cancer while she was on the South Pole at a time of year when they couldn't fly in to get her out. And she was guided through the process, hang on your hats on this one, to perform her own surgical work. She is alive today, guided through telemedicine. And so it becomes this way of using video conferencing for connection, for guidance, for shared information, to have pictures move back and forth, which we call store and forward, or asynchronous transfer of images, to distant learning, to the use of this tool to be able to do research in rural communities or global communities, to improve access to care, to do population health. And in this environment of healthcare reform, we're all going to need to think differently about the health of communities rather than the health care we provide internal into institutions. How do we provide population health, and what role does technology play in improving that health? And a belief that we all need to have that health is fundamental to prosperity. Isn't it the bipartisan issue there? We're so divided as a nation. But the issue for all of us is our communities doing well, prospering, people able to work, to care for their families, to cope with illness. Well, that's about prosperity. And in order to have prosperity, you have to have access to resource. And technology is an efficient way that I hope I show, an efficient way to have that access. Let me say, if you guys along the way here in my, as you can tell, I'm passionate, I'm prone to hyperbole. If you guys want to interrupt, ask a question, don't hesitate to stop me along the way here. This shows you how the access is happening. So since we started this program 20 years ago at the University of Virginia, we've been able to do specialty care in now 40 plus specialties. It begins to be that there's a broad imagination of how you can use this. So we now have a relationship with Pittsburgh and their pediatric transplant program. They have the best pediatric transplant program in the world in Pittsburgh, hands down. Their infection rates, their selection processes, their surgical rates, their care within the hospital, on and on and on and on. Outcomes are fabulous. And so they're a part of the selection process. They sit in talking to the families. The families connect in. The folks from Pittsburgh connect in. The people from UVA connect in. The surgeons connect into the OR. And they are a part of the surgical process. The nurses from Pittsburgh, who are so well trained, connect to the patients, to the nurses on the unit. And they share information about the care of the patients. They see the patients. They follow them up when they go home. This is blowing apart at the seams, the way we're able to do it. How about this one? I love this one. 2 years ago, in Southwest Virginia, we got an emergency call about a snake bite, a kid with a snake bite in an ER. And, they're going to have to start anti-venom treatment. But our toxicologist, because of the high definition capability of the cameras, was able to see that it was a dry bite. and was able to make an instant decision that made a huge difference in that child's life. So you get to see how that could happen in the middle of Africa to a toxicologist that's in Charlottesville, Virginia. These things can happen. So it's very exciting. Currently, we have 24 very active specialty clinics, and they range everything from high-risk obstetrical care, in all kinds of maternal fetal health, to neonatal care. Our relationship with neonatal nurse practitioners, fundamental process, rural hospital with a neonatal NP, talking to a neonatologist in our unit, being able to keep a child there and a family happy with their child there in constant conversation, all the way through stroke care in emergency departments, work in the back of ambulances, care for cancer patients, chronic disease management like endocrine care, care for diabetes, through to Huntington's disease, Parkinson's disease. So we really run the full continuum of healthcare in the clinics that we offer. Can't do it if you can't connect to somewhere. So the one thing that's very powerful about telehealth really is about partnerships. It's not about being at an institution receiving patients. It's about being a part of a community and their overall healthcare needs, whether it's a free clinic, a correctional facility where we have a large captive audience of patients to be able to see. I just think about the dignity of those patients, that opposed to coming into a hospital facility like this, to be able to be seen where they are is so much easier for them, easier for patients in our facility, easier in terms of its cost to the system. So we have a large correctional telehealth program. To other hospital systems, to emergency departments, nursing homes. Needless to say, you think about that patient in that nursing home, an LPN in the middle of the night, having to make a decision about whether or not you call the ambulance and take that person to an emergency room, how good it is to have it confirmed with a physician or a colleague in a nursing or in that emergency department before they make that transfer. Maybe that person doesn't need to go. Maybe they can watch overnight. Maybe they do need to bring the person in. But it's the ability to be able to make efficient, effective decisions about how you provide care. It's not for everything, but it is a very important tool, and it's coming. It's coming. It is going to be a part of your practice. And so the more we get adjusted to this, understand the technology, play with it, the better we're all going to be about it. So what are the benefits? Go ahead.
Did you make a comment about the Habitat for Humanity?
Yes,
Because we have a big chapter here.
well, we're very proud of this. We know we needed to be able to get to the home. It's, this movement, we are in the middle of a paradigm shift away from healthcare to health, right? Who better to lead this, frankly, than nursing, to move this from healthcare to health as the paradigm for how we prepare. And so when you think about that, we have to then move from institutions to the home, institution to the workplace. And so the home is going to be the locus of a great deal of healthcare in the future. Much more so than has been the case. And so we wanted to work with an organization where we knew people had chronic disease, struggled, many of whom had bankruptcies and problems because of chronic healthcare issues, that we wanted to work with Habitat for Humanity, not only to care for those families that were their member families, but actually at the University of Virginia raise the money during our annual campaign, be a part of the team that builds the house. And in building the house, we wired the house, and we worked with engineering, and we put in remote sensors into the house so that we work with people who had fall risks. So we had passive monitors. We even had a monitor in the toilet for blood sugar monitoring that was a passive monitor, a computer access, blood pressure cups, pulse oximetry, body temperature, medication dispensation, so that you could know that the person actually at least took the medicines out of the drawer so that you had compliance. And so we built Health Home. And now we actually at UVA, because of the change with healthcare reform, we actually have a remote patient monitoring program that reaches thousands of patients with those same tools in their homes for patients with COPD and pneumonia and AMI and heart failure, to try to keep those patients home and healthy. So knowing how to use these technologies, knowing how to monitor that, understanding the algorithms, working hard to keep people at home. We've even got health systems out there who are delivering Meals on Wheels now, with the understanding that people maybe need to get nutrition to stay well. The world's changing, and so that Habitat for Humanity was really our learning curve with that, and we're very proud of it. So it is this timely access to care, close to where the person is. For health professionals, it addresses the workforce shortages, keeps a relationship and continuing understanding, and it also enhances the economics of that community. I put Route 90 up there because 90% of the patients who receive telehealth care in their own communities stay in that community for care. It means jobs, it means money in that community. It is fundamentally important rather than draining community to large academic centers. So this is our track record, just to once again reinforce, guys, that this is very much going to be a part of your clinical work. So this is our little program at UVA. We're now about to roll over the 40,000 patient encounter. So it's growing and it's growing and it's growing and it's growing. We'll do 1,000 encounters this month. We'll do close to 5,000 encounters in 24 specialties this year. The number I love is that we've saved Virginians 8.7 million miles of travel to healthcare. So it's green, it's a powerful number.
So you are able to bill for this, that's what's going back in my head as you're talking. Who is paying for this?
There's a mighty fine question. Because the way, we've had certain principles. First of all, telemedicine, telehealth as a capability should not be about the business of going to a community where that service is already available. This is not about, hey, we got a great pediatric pulmonologist, we're going to open us up a telemedicine shop down the street to go head to head with this person. So we made the decision where it's otherwise unavailable. Secondly, we made the decision that it must be standards-based. It can't be at least for the old folks in the room, we can't be using Betamax versus VHS. We all have to be working from the same hymn book here with the same technology that is interoperable. And the third piece that was so important to us is you have to be reimbursed to be able to do this. Telehealth is not free healthcare. Can't be, because it involves technology, it involves broadband. So this involves policy, it involves decisions. So we were very active with federal legislation so that Medicare now provides payment for all telemedicine, rural telemedicine. So right there is an advocacy cause right there. Why shouldn't urban seniors who are bound in their homes, or urban seniors or urban African Americans who don't have access to the finest health care, why would we discriminate against them? So we have some work to do, and we're working with CMS to make those changes. then within each state, Medicaid coverage is critical. In Virginia, we got Medicaid to line up, and Medicaid covers telehealth, all forms of telehealth in Virginia. In Pennsylvania, there's a lot of battling going on about that right now in terms of what Medicaid's going to cover.
And I wanted to say, I sat in at the Capitol of Richmond, the nurse practitioner practice. We've been supervised for so long, as you know. Well, I sat down with a medical society of Virginia that represents all the physicians who are lobbying against nurse practitioners. And I said, let's get the supervision language out, because think about Southwest Virginia where there's nobody around. We've got nurse practitioners down there giving care to people. They're not getting supervised. They said it's collaborative and consultative, and they're using telemedicine. And sure enough, that was like the key. So we just kind of did it in baby steps, but this was the key, was through telemedicine to say, hey, let's back up the supervisory language, and it worked. So.
And then the court came out, because then if working with the Medical Society of Virginia, if they were going to acknowledge that, okay, well, we'll surrender a little of that territory to have collaborative practice, then we pushed and got coverage. The state passed unanimously a mandate that all insurers in Virginia must cover telemedicine. So now Virginia, we're usually 48 out of 50 in the states. We are always very thankful for West Virginia and Mississippi. We now suddenly in Virginia, when the Center for Innovative Technologies goes out and evaluates the nation in terms of application of telehealth, we're number one. We are the United States. It's available now comprehensively so that a nurse practitioner can see a patient somewhere in his or her practice and bill for that encounter at the same rate that you would bill for that encounter if that person walked into your office. Reimbursement changes the landscape, and mandatory reimbursement is going to be, there are now, I think, somewhere 18 to 20 states with mandatory reimbursement, and Pennsylvania has a major push. There's some great leadership in Pennsylvania to move that forward. So it's coming, because the cost efficiency of it is going to drive it to come. But that was a very important question, and this is what drives that. Now, my colleagues in my Office of Telemedicine that work with me at UVA call this the cobra ready to bite us at any time, because, of course, they haven't seen fit to raise the number of staff doing that work. But that's a 465% increase. So you can see how this is growing. This changed right here. That little dip was when our colleagues across the state, VCU, Virginia Commonwealth University, decided we're going to get in the business too. And it changed things with correctional facilities and other parts of our business. But you can see that that's just been an unbelievable ascent. It's dizzying. And this year will be the biggest year ever. And the next 2 years will be bigger than that. Because this technology is so compelling. Because we use it in lots of ways. First and foremost, and this is another principle, like going where it's otherwise unavailable, being standards-based and interoperable, ensuring reimbursement. And the fourth thing is confidentiality, security, compliance with HIPAA. I go up onto one of the surgical units the other day, and there is one of really a great nurse bedside like this. And she's talking to a physician, and they've got the patient, right? She's holding the phone, the doc's talking to the patient, she's talking to the doc. And so as quietly as I could, I said, so how are you connecting? Oh, FaceTime, we do it all the time. If you're in an environment where somebody's using FaceTime to connect, to exchange health information, stop it right there, however you can, because you're engaged in a HIPAA violation at that moment. Because as you guys know, Skype, it goes out into a big cloud. We don't have control over that information. It's fractured, it moves forward in complex ways. But in order for all this to work, it has to be secure transmissions. And that's a very critical piece. And we have infrastructure and backends that I won't go into now to tell you how secure it is. But we use all these tools. And we are not far away from moving to mobile tools. The smartphone, this thing will become indispensable to you as a healthcare tool. I don't know how many of you may already be using it in some fundamental ways. But the iPad, the iPhone, tablets, droids, whatever they are going to be indispensable. Who knows what that is? Google Glass. So, okay, I was poo-pooing that, but we have Google Glass now. And it's in research and development, but here we go. So we've got a doc in the ED, right? Stroke neurologist, and he's got him on, and he sees an anomaly, and he's got a colleague back in his office, and he wants him to see that anomaly. He wants to confer. So his colleague puts his Google Glass on, and they're looking at the same thing, and they're talking to each other. And they're using our network, our secure network, to do it. So the day is coming. The iPad. So we have a secure transmission from the back of an ambulance where you have an EMS worker, and they have, one of the issues with stroke is you're losing 10,000 neurons every minute during an ischemic stroke. So you've got a person holding an iPad over the patient, and the stroke neurologist sees that patient, the patient sees the stroke neurologist. They're making a decision, they're doing the NIH stroke scale, which is critical to making the determination as to whether they believe it to be a stroke and whether a CT scan is necessary as the next stop. So they make that determination. That patient comes into the hospital. They don't stop at the door. They don't get admitted into the ED in the same way. They don't sit in a bay waiting for the stroke neurologist to get there, to come there to do that. They go straight to the CT. We're saving on average almost 20 minutes by using an iPad. So if we don't, if we're not thoroughly convinced and passionate that this is going to be a part of efficient, good care for people, we're missing something, because it really does matter. These tools have extraordinary capacity to change the way we do things, but it's scary too. So let me put out one other piece where I feel like you guys need to talk about this in your classes. When you talk about telehealth, there's a huge ethical dilemma here that has to be discussed. How many of you believe we're going to have chips inserted in our hands that'll carry our medical records within, let's say, 5 years? I do. So that our entire medical records going to be right there. We're going to put it under a scanner, and they're going to know. And it won't be very long from that where it'll contain our entire DNA sequence in that little chip in our hands. It's scary, isn't it? I mean, it has to provoke this question about privacy and how we're going to do things, but we have to have that discussion along with the fact that we're going to restore sight. We're going to be able to provide care in places that we haven't otherwise provided. We're going to be able to do miraculous things, and already do with this technology. But we have to ask, the largest maker of those little set-top boxes that Comcast put in our homes so we can watch 700 channels of basketball, that's Cisco makes those. And Comcast, you better believe, wants to be in the healthcare industry. And so what they're developing is channel 733, which is, David's personal health channel. And so I'll just go into my health channel, and I'm going to Bluetooth in my blood pressure and my glucose. And I can see my trends. I can see them going across the screen. And I can hit the button, and I will have a secure transmission into my nurse practitioner who's going to say, you know, we're going to need to change your blood pressure medication. Look at how this is trending and stuff. And I'm going to have my evaluation that way. And that's going to be in my home. We're going to age in place. Nursing home facilities don't really work for the dignity of human beings well. And so we're going to stay in our homes longer, and we're going to use this technology to manage it. But I get a little scared when I think about retinal scans and the loss of privacy and the fact that everybody knows where I am all the time. So balancing privacy, security with technology that makes a difference for families that don't have access to health care, we have to have those discussions. And those discussions need to happen with the people who are up close, who are caring for the patients, and the people who are teaching them about that care. It is going to be a huge challenge in the next 5 years. The next 5 years are the critical 5 years in what happens with all this technology. And our job, my job in telehealth, your job in nursing and in education, is to keep remembering that what is sacred in this is about place and relationship. When it comes to health, place matters. Place is as fundamental as things like race and gender in determining how we do in our health. And so place matters, and the relationship that we have in that place matters. Go back and look at that 60 Minutes episode from Sunday night. Those two women, Paula Mead, Teresa Gardner, nurse practitioners in Wise and Clintwood, Virginia, and look at the work that they're doing to keep the world taped together. They are extraordinary. It is a very, very remarkable story that I really do urge you to look at. For us at UVA, and I wanted to talk very briefly about the impact of telehealth in regions of health disparity. University of Virginia, I asked students, so how many of you applied to an Appalachian university? And no one raises their hand. And then I throw this up there and say, wow, surprising, isn't it? We are adjacent to 25 Appalachian regional counties in Virginia. We serve this population. Those are the most economically distressed counties in the United States. If we are not responsible for the healthcare providers and the health outcomes of those counties, who the heck is? And so what role does this technology have in addressing health disparities? And so when we look at our map of where we have in all those partner sites, free clinics and federally qualified community health centers and small rural hospitals, you'll see the proliferation of them is really down in Appalachia, in the farthest most reaches of the state. And when you overlay that over the health disparities, and if you guys haven't looked at that, it is very important to look at. Every year, there are county health rankings that come out. Robert Wood Johnson funds this through University of Wisconsin. They do a lot of work there. It's remarkable data. And so you can pick your own home county. You can pick any state. You can look at the factors, the health factors, and you can look at the health outcome factors. And so when I look at this is Albemarle, where the University of Virginia is right there. These are the Appalachian counties that are suffering horribly. They are at the bottom of the heap, whatever it is, whether it's infant mortality or preterm delivery or diabetes rates or obesity or cholesterol rates. The only thing that they lead the state in is in not having a sunburn within the last year. And the reason they lead the state in that is because they have no leisure activities. They don't get outside to get a sunburn. And so you have this horrible health situation. And so whenever you have a public health issue like this, which is an epidemic, it's an epidemic that's affecting every community across the United States now, which is the use of opioids. We have a mortality rate now that is 40 deaths per 100,000 people adjusted in Central Appalachia from opioid use, is what you might see on TV and Justified in the TV series is true. The opioid use is at epidemic levels. It causes huge ramifications to communities and breaking apart families and the loss of work and the inability to pass a drug screen to even get a job. But you look at this and you say, what is our responsibility? And you have to say, well, if part of what creates this is the pain paradox of disabled miners and workers and rural workers and agricultural workers, what role, for instance, can telemedicine play in providing nurse practitioners trained in pain management to be able to reach into these rural communities to provide alternative methodologies for the management of that pain? Because I can tell you what, there's nobody there who can do it now. And so we have a public health epidemic. And so here's what we have instead. And this shows you the scope of the health disparity. And if you watch that 60 Minutes, you see the people who are at the lead of this. So we have every year what's called the RAM Clinic in Wise, Virginia. It is the largest free screening clinic in the Western Hemisphere. More than 7,000 people will line up for 2.5 days of free care. We will extract more than 10,000 teeth in lawn chairs, in a stall. We will do flex SIGs in a horse stall. We will have those people do their colon preps in porta potties that they share with 7,000 of their closest friends. This is healthcare delivered in the United States. And we don't talk about this. We don't see the abject horror of this kind of health disparity of people lined up like that to try to get basic health care. More than 60% of the people who come through there have elevated blood sugars. We have an epidemic. And so we have to find ways to use this technology to improve lives, to even save lives. Because there is an extraordinary, ethical issues aside, struggles aside, we save lives with this. This little kid who is wonderful, and by the way, has given families given permission for the use of his picture in his name, was born on Y2K, and we were in a panic. Everything is going to shut down, nothing's going to work. So the baby's born in a rural hospital. A cardiologist looks at the baby and says, I don't know, he's under such stress, we don't know what's happening. And we were able to hook up an echocardiogram and look from where we were. Our pediatric cardiologist instantly said, that's an interrupted aortic arch. Prostaglandin gave the kid the drug. We had an ice storm to boot, but got him in an ambulance, got him the drugs, and he's a healthy, happy 14-year-old boy. That's what telemedicine can do. This little girl who had this terrible facial hemangioma, and her mom was the secretary in a health clinic that had telemedicine. And she was driving 4 hours to bring her daughter up to see the plastic surgeon there, Catlin, to say, and they'd sit down in the office and he'd look at it and look at her blood work and say, yep, things are progressing, that's good, I'll see you in a month, right? And they'd turn around, they'd drive back. She'd miss a day of work, have a screaming kid in the car. So telemedicine then creates the opportunity for that little girl to be seen through the process, reducing the number of visits. And there she is. And that was at the BIPA hearings in Washington when she testified before Congress on telehealth and Medicare was approved and there wasn't a dry eye in the house. So that's another, if you're ever going to win in a policy debate, take a cute kid with you. It's a guaranteed winner. It's a real advantage. So she's wonderful in doing well. We reach into schools. Think of the support for school-based nursing and how you have these kids in Craig County whose school nurse is able to connect to a Nobel laureate at the University of Virginia to be able to do a lecture in physiology, or to connect to Sally Ride, an astronaut from the Challenger, to lecture in their science class on physics. Or, you begin to see we can make the world smaller. We can engage those kids about their health. We can keep them in school rather than losing school time for issues. It goes on and on. Our high-risk OB program is the one for which we are most proud, that we believe is an extraordinary example of reducing health disparities through the use of technology. So as you see those numbers, you think about a woman, a migrant worker in a rural area, speaks Spanish. So there are no high-risk obstetricians outside of academic centers. Where is she going to see that obstetrician? She's going to have to borrow a car, get in a van, bum a ride, come up with money, drive for hours to be able to be seen. So she's not going to show up. She's not going to get there. She's going to manage the best way she can. But imagine she only has to go 2.5 miles down the road, see that same obstetrician, get her care managed, develop a relationship with a nurse practitioner at the health department in a maternal fetal program. And so she comes into care earlier, right, which is critical. We've cut the number of appointments, and by the way, this is a cohort of 600 cases. And we have reduced preterm delivery by 25%. Is there anyone who would question how valuable that is to a family, how important it is to a child, what that means in terms of a lifetime of learning and health, what it means to the family and work? And this is something that can be a model that can be applied everywhere, not only in this country, but around the world. This begins to be an example of how you can make this work. The same is true in stroke. This is now becoming the standard of care. The day is coming where you will not get a job in an emergency department as a nurse and not have a telemedicine camera in the bays and in where you work. It's going to be there in every element. And stroke is the number one reason it's going to get there. We've changed the landscape of because people are late getting into the ED already. And when we can get them in there and get through PACS, we can get head CTs transmitted quickly. Our average is now we have our stroke neurologists at the bedside with the patient within 4 minutes, seeing the patient, making a determination, is it an ischemic stroke? Do we need to give a clot-busting, life-saving drug? How can we do this? And you can see in this number, we're changing the practice in hospitals. We're changing the skill set and the capabilities in those rural hospitals, and we're improving the outcomes in communities, and we're sending people back to work. We got 1 million of them. And I won't go through all of them, but this is how it can be used as an efficient tool, whether it's diabetic retinopathy screenings. We have a mechanism now, low-cost camera, and you can imagine this all over the world. Nurses train, take the picture of the retina, it Bluetooths right into a computer, push the send button. Dr. Yates got his smartphone, it bings, he opens it up. There's the retina, that's the patient information, stretches it, says that person needs treatment, hits that text that says we need to do this to arrange the appointment for the follow-up care for that patient. Boom, under 2 minutes. It's already happening. That's already a capability that's out there. And so you as healthcare providers need to know that this becomes, the way that we process a lot of these. Pediatric emergencies. There are very few emergency departments, especially in rural communities, where there are trained pediatric medicine folks available. This becomes the standard of care. HIV/AIDS over and over again in settings all around the world. This becomes the means with which ID physicians, NPs, others can manage the care and use of antiretrovirals. We've shown extraordinary success rates in that. Cancer outreach. ELCI has been critical in developing in Appalachia a program that has a very high rate of cervical disease. And cervical disease, you guys know, all around the world, outside of childbirth, is the #1 killer of women around the world. We started a program together in Southwest Virginia where nurse practitioners would be trained to do colposcopy, and they would, in their connections in the community, bring women in. They do the colpo, and we have a great GYN oncologist who watches the examination of that cervix with them, because it's all fiber optics, right? And so they're looking at the cervix, they're making a decision about where to biopsy, what kind of treatment is going to be necessary. And now in a region that had no providers of colposcopy, in that same region in Southwest Virginia, there are 5 nurse practitioners delivering that service every month. So now there's a resource. And I'll talk a little more about how that moves out globally. And as a result, we've begun to set up a whole network then across the state of Virginia, using nurses as a primary tool for nursing screening, using video conferencing as the means for connection. Telemental health, of course, this is a no-brainer, right? This is about relationships, it's about med management, it's about seeing people in a timely basis. Our largest provider of telehealth services at UVA is child and family psychiatry. We reach into every community service board across the state where there are no child psychiatrists. And PNPs, psychiatric nurse practitioners, they're not PNPs, are they? I knew I made a mistake as soon as I said that. But nurse practitioners provide therapeutic care to those families. Child psychiatrists support those encounters. Those kids don't miss schools. The families are able to stay at home. This becomes a critical way. We do it in ICUs. You know, a place like Alaska, look at that, a 31% decrease in the use of antibiotics when you use the otoscope. So, you know, it's a great way to go. You're beaming that in. A community health worker can connect to a provider, and they can make a decision about an ear infection. The other area I really wanted to talk about, because it's an area of interest, especially for you guys, is how you develop global programs. Using telehealth is a key component. The world has changed because of cell signal. And developing nations are moving quickly to be able to use cell for banking, for all kinds of e-commerce, for connection. In Tanzania, one of the poorest countries on earth, there is a cell phone for every 2 people. 5 years ago, we would, in Tanzania, you would say, no, that's not possible. So now suddenly the landscape has changed. The Chinese are there rapidly building fiber optic systems throughout all of Africa. And suddenly things that you didn't think were possible are possible. So the program that ELCI helped start in Southwest Virginia now has morphed into a program for Maasai tribal women in northern Tanzania. And so the health team will go in to a Maasai tribal village. There is no, I'm talking no electricity, right? Dirt floors. Maasai tribal woman who has never had a GYN exam in her life. So this is all going to be a pretty strange experience to begin with, right? Is getting a GYN exam. And during that GYN exam, a photograph is taken of the cervix. So you can use digital photography, and then that Bluetooths into an iPad mini. And that iPad mini has a shaved down SIM card in it that works in Tanzania. And that image, as you know, on a retinal screen iPad, you can look at that in a high definition way. You can expand that image, look closely at what that issue is, and then using the cell signal, the 4 bars, I was able to be in the middle of the Ngorongoro crater 4 hours away from a city and look at zebras and call my mom and say, "You're never going to believe where I am right now." Well, that person can send that image to the Kilimanjaro Medical Center, to Duke University, to UVA, and people are able to make decisions right then and there about, okay, cryo is going to be the necessary choice here, and able to send that person in for care. This is in a place where communication is not really possible other than through cell, but these begin to be the tools. And so now we have evolving programs where in Rwanda, we reach into Rwanda every other week now with surgical training conferences, anesthesiology training conferences, nursing meetings. We have a network of 7 nursing schools that come through our bridge at UVA, and we have meetings where nurses at UVA and nursing faculty at UVA talk to nursing students in Rwanda. They teach us about tropical disease, they teach us about HIV, they teach us about compassionate hospice care. We teach them about medication management. We're able to share remarkable things. We do this in St. Kitts, for instance, and the nursing students are able to meet the folks in St. Kitts before they go down during the J term, begin to have images sent to provide the care. The Swinfen Global Trust that we're a part of, I can't tell you how amazing it is to come into work in the morning, how much I love this. Come into work, there's an email in our inbox from a woman in Nepal who has had 7 miscarriages. And she's not a high-tech woman. She's wandered into a community that had an internet cafe. And she found in that internet cafe, she went out and looked for programs that might help her. And she was just firing off emails because her identity was bound in her being able to have a successful baby. And so we happened to get an email. So we're part of the Swinfen Global Trust. So we send that email on to Lady Swinfen outside of London, who knows the librarian in the community where they are because there's a Swinfen hospital in Kathmandu, and that Swinfen, that librarian finds the woman, takes her to the hospital in Kathmandu, and they connect to a high-risk obstetrician in London who helps guide her pregnancy. That's just one story, but we're talking about winning the hearts and minds of people over the globe. This is the way we're going to do this. This is available to us. These capabilities in these countries, and whether it's teaching, whether it is the use of medications, whether it's the experience of traveling there, whatever it is, we have this chance to change the world. Lady Swinfen is a nurse. She could have chosen her life to, her husband, Lord Swinfen, has the Charles ears. He's in the direct royal family, and they could have spent their life in their country home. But they run a telemedicine relay station there that connects people in 235 hospitals in the developing world through simple telemedicine capabilities to get care every day. That's what nurses do. That's why these capabilities really are such a natural. And so now you can see our program, which started small now. So it's not only reaching the health disparities in Southwest Virginia at home, but it's also being able to reach on a regular basis. We talk to people every day all around the globe, not through just email, but we see them face to face. And I can tell you, in that same 5-year span in which all this is going to change, none of us are going to use telephones anymore. I mean, we're going to have smartphones, but when we make a phone call, we're going to be looking at the person. When we sit at our computers on our desks, we're going to be looking at the person we're talking to. We're not going to be talking on a phone like this anymore. That's all going away. It's all going to the world of video conferencing and seeing each other. So then you might laugh and say to me, well, yeah, but you still can't smell the wound, you know. Well, and I thought, well, shoot, yeah, that's right. There are limits to what this is going to be. And then, I don't know if y'all saw in Science Magazine last month, scientists at Rockefeller University were able to determine that actually we can sense more than 1 trillion smells as human beings. We're closer to dogs than we thought. And we can, and the way they did it was through molecular structure of smells. So they were able to take a molecular structure of a smell and test the sense and then a human sense of how they perceive that smell, and then build out the algorithm to be able to count how many smells, how many combinations of those in that algorithm, how many smells you could smell. Well, so then some smart person says, well, so then it's really capable to build a device that takes those chemical arrays in molecular structure and be able to translate that from one location to another so that it actually tells you what that molecular structure is of that smell, so you could actually smell that. Well, not that any of us really want to do that. Let's not go there. Let's just video conference. I love to see all of your lovely faces, and that's the way to do this. Whether it's chronic disease management, whether it's emergency departments, whether it's store and forward, whether it's global telehealth or academic centers or high-risk obstetrics, we are moving there. And so in addition to the integration in our education, the ethical discussions we need to have, this is what the world, and now if you look at the funding sources, and this is important to the faculty here in guiding these things, there are dollars, lots of both federal and state dollars that want to fuel nursing engagement in telehealth. HRSA is, the HRSA Office to Advance Telehealth is very aggressive about wanting to develop this. We have a Villanova partner that sits in the head chair of the School of Nursing at the University of Virginia. I'm proud to say a Villanova graduate is the dean of the School of Nursing at UVA, where I am, who wants to see this develop. Partnerships are going to need to develop about how it folds into the curriculum, how it's used to reach out, and so the funding is enormous. I think we've just our little teeny Center for Telehealth at UVA, we're at about, what, $10 or $11 million over the last 7 or 8 years in grants to develop telehealth. So the resources are there. There are challenges in Pennsylvania in the issue of reimbursement and how it happens, ensuring confidentiality. Licensure, ironic things about licensure. The whole nursing solved this compact question a long time ago. We're going to have to figure it out for telehealth. We can't see a patient in West Virginia because of malpractice, but that patient can come to Virginia and we can see it. So it has to do with the location of the doctor and not the patient, or the patient and not the doctor. It's an ironic thing. But we're working all those things and how it integrates. And then there's huge opportunities, again, both in historical inquiry and the role of nursing practice in the development of telehealth. Look out there, there's not a lot published. There's a big meeting in mid-May, the American Telemedicine Association's meeting in Baltimore, so it's close to you guys. I would urge someone to go. There is a nursing special interest group there that's very active. There's a lot of money to be found in those conversations, opportunities for research, and especially looking at outcomes in nursing practice. Getting this reimbursement, because it varies so much, it's made all the difference in Virginia. It affects nursing practice. It affects the way we're going to go forward. I want to tell you the only malpractice issue, because it always comes up, the only malpractice issue that we've had in Virginia over all these years is a woman who was being treated for shingles in Southwest Virginia, and it was getting progressively worse and worse, and she knew the hospital had telehealth capabilities, and she demanded to be seen by a dermatologist, and she had, a flesh-eating staph infection and had to be taken immediately to the OR, and she sued for the lack of use of telemedicine, not because telemedicine was used. So it is changing community standards. When you can have access to a resource and you choose not to have access to that resource, it's a real issue. So there's a lot in outcomes, in the standards, in the etiquettes, in the nature of our practice, how we, the broadband's getting better and better and better. Capabilities are getting better and better and better. How we integrate cell into the work, how it gets incorporated into nursing, how we view it in our definitions of interprofessional practice as we structure that. And just to develop champions, that's the key. Champions makes this work. So that's the gap we go across in Southwest Virginia. That's the largest canyon east of the Grand Canyon at Breaks International State Park between Virginia and Kentucky. And if we can get across that with telemedicine, we can get across anything. So, questions?